Good morning. This is Ellen Brown with Glenridge Healthcare Solutions, and I'm here with Nicole Lucas. And welcome to our webinar today on discovering how to use the right data to make accepting risk less risky. I'm just going to pause another minute just to make sure everyone's on. I'm looking at our tech support here just to make sure we aren't having any issues. Okay, I think we are ready to go. So, first, I just want to take a minute to orient everybody to Glenridge. Those of you that are not familiar with our firm, we appreciate you joining and hope this is a good introduction to some of the services that we offer. So just very quickly, I can tell you we basically have two main components of our firm, and one is strategic consulting and advisory services, and that's what we're going to focus on today. But we also have a full implementation network management component to our firm. And as you'll see when we go through, we'll talk about some of the tools and techniques for managing networks. And a lot of times from an accountable care organization, ACO, clinically integrated network perspective, we don't think of networks as necessarily relevant, but truly you are in essence becoming a payer of sorts when you create these types of mechanisms and contract with payers. And so as a result, we really think that there's a need to look at the network that you have, the network that you manage, and the network that you bring to the table. And so within our firm, we also, not only do we do all of the analytics and the advisory services, but we also help execute networks, optimize networks, reconfigure networks, all sorts of things. And we work equally between provider organizations, accountable care organizations, clinically integrated networks, as well as insurance companies and payers. And this next slide, so in terms of our client base, you can see on this particular slide that we have over 15 years of history, and we have worked with all the major payers and a lot of leading regional payers, and we've also worked with some very exciting clients from a health system perspective and are currently, and we typically have very long-term relationships with our clients. So what are we going to cover today? So when we talk about making risk less risky, we thought we would cover really three main components of that. And so what we think is helpful is, first, why take risk? There's a lot of question about, should I take risk? Should I not take risk? And so why take risk? The second question is understand your ecosystem. So understand the providers and how they're participating, how they are relating to each other, how they're performing, and then understand the foundation that you've established with your accountable care organization. And then finally, monetize your ecosystem. I know a few of you joined us a few weeks ago for our Monetize session and talking about value-based contracting. And the reality is that we're going to spend a lot of time today talking about how you evaluate the performance of your ACO and educate your ACO. But I think the most important piece here is you can do that all day long, but if you aren't monetizing the end result, then you aren't going to have a long-term sustainability around your accountable care organization. So the first thing that we're going to talk about here is educate and understand the why. And I don't want to underemphasize this. Again, so many folks right now are so focused on the analytics, and we are very focused on the analytics. However, what we find is a lot of times providers are not engaged and ACOs are not willing to take risk. And the truth of the matter is half of the battle is that they're just not educated on why. They don't feel like there's a burning platform. They don't even understand necessarily what risk really means. They had bad experiences back in the 90s or back in the 80s or in the early part of this decade, and as a result, they're not interested in it. And so one of the most important fundamentals is to get agreement within the organization and within the key stakeholders, so your physician leaders, your ACO participating physicians, all the folks that are really fundamental to change and driving change, is helping them understand your organization's perspective on value-based care and how we're moving from fee-for-service-based care to value-based care delivery. If without a fundamental agreement and education around that, then folks all have their own understanding and their own belief, and they just aren't willing to take risk. So again, education is absolutely paramount and one of the fundamental components to making risk less risky. Educating on why take risk from a rewards perspective. So when you look at the visual here, and again, those of you that were with us a few weeks ago, we used a similar visual, but the message was different. And what this really talks about is the fact that you have to take meaningful risk to get a meaningful reward. So if you're only going to take upside risk, the corridor of reward that you can receive is very narrow. So, everybody talks about MSSP and, we've done MSSP, but the true thing is that the levers that you can pull for MSSP and the final reward of MSSP, and this is on the upside only track, not next gen or some of the newer things that are now coming into play. But most of our clients, when we model out for them what MSSP could really deliver, it's not very meaningful because there's not a downside risk component to it. And I know some folks took a different track with MSSP and saw different results, but the bottom line is the more risk you take, the more meaningful the reward. And it's also the more meaningful the ability to influence your reward. So when you talk about percent of premium arrangements or global risk or health plan ownership, and even in some cases PCMH, ACOs and CINs that contract in those arrangements always look at making sure that they have the controls they need as partners in that venture to be successful at taking that amount of risk. So can they be involved in benefit design in the health plan? So can they make sure that, for example, there's a $0 primary care copay, or that, that members have access to wellness care and that it's covered, that there's educational support, that there's chronic and complex programs to support disease management. It's making sure that all of the key constituents to being successful as a health plan are engaged. And so typically in these arrangements, you have the ability to influence that. The next piece are critical components to successfully accepting risk. So I broke this down into 3 components and really thinking about the reward and the risk. So again, educate. So understand how to manage risk and what risk means. Model potential risk strategies, the contract structures, and the incentives. So helping people understand what it is that you're asking them to do and why creates engagement. The second piece is evaluate. Evaluate what you want to do. Model it. Look at it. Evaluate your current position. Evaluate your current performance. Make sure that you have metrics that you're evaluating on a regular basis, and not just at the individual provider level, but as an entire ecosystem. You are providing a care delivery mechanism as an ACO. You are a system of care that a payer is contracting with, which means that you're providing a level of integrated delivery that they don't have to worry about. And the value you bring is not just the number of providers that you're delivering, but the fact that you're creating an entire ecosystem that you're handing over to them, and you're making a commitment to say, hey, we're going to deliver here. We're going to be, cost effective, and we're going to provide high level of quality and ultimately bring you a high level of satisfaction to your membership because of our accountable care organization. And so, again, you'll hear us say a lot, think like a payer. So think about what you bring from a payer perspective, and that's part of the evaluation process. And then finally, engage. So you have to engage the physicians. Enable value-based care transformation. So many times we see organizations that have siloed an ACO over to the side, and the overall parent organization sees that as this side venture, and they haven't truly embraced that value-based care is happening. And I don't want to sound like we're saying that within 2 years you have to move to 100% of your revenue in a value-based agreement. That's not at all. You may decide that it's going to take you 20 years. but it's the fact that you know that there will be some level of transformation and that the framework and the contracts to support that occurring is in place. And once you have that, and once you can establish that and show and demonstrate that to your physicians, you can engage them because they see the vision, they understand, and they're excited to be a part of it. Establish a meaningful reward. Notice we didn't say $1 incentive or it has to be X numbers of dollars. So many times physicians are just as happy to have a seat at the table to be able to voice how their future destiny looks as they are to get an extra $20,000. There are a lot of physicians, I understand that they're all about just the numbers. But establishing an overall incentive program that is beyond just the reward in terms of plain dollars. So are you providing them a level of things and technology and tools and education and patients and members? We have one client that because of their financial system of care and all sorts of different reasons, they've said, hey, what we're really looking at is growing the overall footprint of the system and the overall revenue of the system. And so what we'd like to do is create an incentive that if our accountable care physicians and our accountable care organization and clinically integrated network participants support growing the overall system because of the high level of quality and the high level of satisfaction that they're delivering and the cost performance to payers, then we want to incentivize them. And so they're tying their incentive to that. So you can be very creative about what you do, but it goes back to that educate and evaluate and understand so that you can align it to that. And then finally, develop competencies in clinical performance management, in clinical integration, and population management. So not that these are, I don't want to sound like they're perfunctory, but they are absolutely paramount and core, but it's these other components that if you don't do them, then those pieces will fall flat. And then creating the risk arrangements to monetize it. And so, you have the reward, and I know this visual probably looks a little, it might be a little bit unclear on some of your screens, and we apologize for that, but I can tell you that from a reward perspective is you want to make sure that your payment incentives are aligned to the metrics that you're delivering on. It enhances your payer relationships. You want to make sure you're improving patient outcomes, access, and experience, so this all gets back to the triple aim. And then increased physician loyalty is really important to this, to make sure that the reward does that. And then the risk is that, at the end of the day, if you don't deliver, then you aren't going to be successful in the future. The reimbursement methods are changing, and depending on how you want to accept it, there is still a level of risk that's coming into play. And then finally, evaluate the current state and establish the necessary foundation. So this is where a lot of people are focused, is they're focused on, do I have my pop health strategy? Do I have the governance structure? Do I have IT? But they aren't necessarily looking at having a comprehensive provider network from a payer's perspective. They may be looking at it from a market share perspective as a health system, but they're not looking at it from a payer's perspective of what value it brings to the member and what value it brings to the region and what value it brings to the segment, and we're going to talk about that some. And then finally, strong financial and market position, again, not just as the health system, but as a provider of care to a health plan. So how do you bridge, be on both components, both pieces of that fence, I guess, as you move forward. And then finally, after you've educated and you've evaluated, you engage your providers and you start to move them along the risk continuum to maximize accountability. And so as they understand where you're headed, as they understand the future state, they're much more willing to move along these continuums. And the exciting part is when you look at the bullet points underneath each of these doors, what's under door number 1 or what's behind door number 2, most providers, they want to deliver integrated care. They want to be part of a well-oiled machine that really takes care of their patients. with a high level of quality, and they want to be rewarded for delivering that type of care. But so many times they're just not educated, and they don't feel engaged, and they feel like they're just chasing the dollar, that they don't want to adopt and adhere to some of these strategies. And we've seen in some markets that payers drop in some of these types of things like PCMH or other programs to push their own agenda on provider organizations. And so that's the other reason that we say, look at taking risk, because at the end of the day, over 85% of the spend that a payer has, and many times it's over 85% of the spend that a payer has, is on actual health care. And so they will look to pull the levers and make the changes and force it to happen one way or the other. And if you take the risk yourself and you engage with the payer to take the responsibility, then you have the ability to influence the change the way that you want to see it change, as opposed to the payer enforcing their own mechanisms to remain profitable and viable as cost pressures continue. So at this point, we're going to jump into some of the tools and techniques that we use on what we'll say understanding and monetizing your network value through our EcoPath system. And at the center of it all, it comes back to value. We talk about value, 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 and you have to have your own definition of value. And it's the equation of cost and quality. And you need to have this. We have this circle of ways to look at it, which is all the things that you need to do. You still have to monitor this on an ongoing basis. It can't be episodic. So we look at alignment, right? So alignment is key to understanding your ecosystem. So what is your provider ecosystem? Who are the physicians? How are they aligned, or are they aligned? Are they aligned to a health system? Where are they going? And again, a lot of folks are looking at this, but they're not looking at the entire region in their marketplace. They're only looking at their own data set. So we'll look at, in a Medicare population, we'll take the entire CMS data set and we'll look at what the region and the ecosystem actually is outside of just someone's ACO. So we can unpack what the dynamics are outside of what they're actually experiencing. So where are things going that are not going to them, and can they change that? A lot of times we'll get lists of providers that are considered they're kind of the biggest advocates or the most important components to someone's network, and we actually look at their alignment to this quote-unquote network or health system, and they may actually be the most loosely aligned at the end of the day. And there's a whole slew of providers that are really closely aligned when you look at their behaviors, and the health system or the ACO didn't even know it. And so really understanding what's going on. Looking at then the performance. So this is where we can do a hybrid of taking external benchmark data, but then also taking client data or payer data and or all these different things, and then looking at the performance from a cost and a quality perspective. And again, everyone's doing a level of profiling, and we recognize that. But there are consequences that happen when you only look at a provider-specific or a specialty-specific profiling tool. So you can certainly look at, all of your cardiologists and say, oh, these are the top cardiologists that I have. These are the top primary cares that I have. These are the top gastros that I have. But the reality is those providers work together in an ecosystem. And so if you just look at that one specialty and you just look at that one set of providers or just that one provider, you're not taking into account how that provider trickles all the way down through the system of care of a specific population. So it really is a system of care, and looking at it from that perspective and understanding the implications of that system of care and how you drive it. And then finally, creating the monetization of this. So you can have analysis paralysis, but if you're not aligning your payer contracts to reward you for where you are doing a good job, then you have a challenge. And again, we see a lot of times that at the lack of knowledge and the lack of understanding of how folks are performing, they go out and they get these payer contracts because that's what the payer offers, and they aren't educated to know what their options are or where they're performing well. They sign up for them, and lo and behold, they have some real areas of strength that are not aligned with the contract that they just signed, and it's because they didn't evaluate and they didn't educate. So I am going to hand this, actually I think I'm going to hit another slide or two, and then I'm going to hand it over to Nicole to actually walk us through. So the first piece that we're talking about here is tracking the financial health and network strategy through data analysis. And so I hit on this on the previous slide, but understanding your performance, what is your total medical expense? What are the cost drivers across your population, and what are the quality performance for measures aligned with your incentives? So don't just look at the measures that some other ACO is looking at, or the guy that sat next to you at the last conference you attended. Instead, looking at where you're performing well and making sure that those are the measures that you're aligning with your payer contracts, or those are the things that you're aligning with your incentives. Try to really maximize your benefit from those. Reducing leakage, a lot of folks, again, are looking at this, but they're looking at it with their own data. They're not looking at the broad perspective and the implications of the whole ecosystem, right? And then maximizing your value-based arrangements and reimbursement, and then gaining insight into your provider relationships, and then understanding how that impacts the payer, capturing member experience, delivery of care, referral patterns, all of these things then, filter into payer arrangements. So with that, I am going to hand it over to Nicole to actually start to talk about how to look at your ecosystem.
Good afternoon, or good morning still. As Ellen had indicated, with continued emphasis on value-based reimbursement, managing care delivery networks from wellness to post-acute along the continuum is more critical than ever. Therefore, as Ellen had led into, gaining insight into provider relationships is really a fundamental element in building a relationship with providers and payers so we can lead to improved member experience and the overall delivery of care. Now, one of the biggest opportunities to effectively manage networks and grow revenue is to understand these referral patterns of your physicians and or facilities. Understanding where the natural alignment exists and how patients flow through the provider's care networks allows you to pinpoint areas for growth. So our EcoPath product is an analytic tool which was developed to support more effective management, the network management, as it is designed to help evaluate these referral patterns and out-of-network service utilization. So here in this graphic that you can see, this is where we really segment the providers into cohorts to allow you to understand their natural alignment and how these patients flow through their behavior. On the next slide, we talk a little bit more about how to manage the care across this continuum and track the referral patterns. Now, ACOs may lack additional information about how to better manage their physician networks, which, as we know, is a critical competency to succeed under risk contracts. Even when ACOs gain access to claims data, they may lack the expertise or resources to conduct regular analyses and to identify opportunities for improvement. So in order to succeed under these types of risk contracts, ACOs need to successfully manage this care across the continuum, including services that attributed patients receive both in and out of network. One of the most effective ways to manage the network is to reduce these out-of-network service utilization and ensure appropriate referral patterns. And the biggest way to be able to do this is be able to visualize and have reports indicating such patterns. So shown on this slide is the two types of referral reports, one indicating both inbound or in-network and outbound network at the detailed provider level, as well as the network referral details between par to par, which indicating the loyalty of your providers, and then as well as from par to non-par, highlighting much more of your leakage pattern, and then non-par to par showing the opportunities that may exist. So by using EcoPath, the executive team can quickly see individual providers' alignment, leakage, and volumes. Here you can evaluate the out-of-network service utilization and referral patterns at the individual provider level within this report that you're looking at here. This report allows you to target providers with education on best referral practices. The anticipated improvements by understanding these referral patterns, you could reduce costs, reduce leakage, with additional successes to be measured. You could measure this by identifying potential savings from improving in-network referral rates, as well as the leakage and referral improvement. Focusing on an ecosystem, here is an illustrative example of understanding the provider's relationships with ACOs and the alignment of their cohorts. So on the left-hand side, you can see this is a graphic just highlighting here's the volume of PCPs and hospitals in a certain region. And then on the right-hand side, this is the regional view of the universe with the ACO participation. So this is indicating the alignment of each one of the providers to the respective facilities, as well as which providers and hospitals are aligned to which ACOs. Segmenting providers into these alignment cohorts, again, based on their referral pathways, and aggregating the practice patterns provides insights into the footprint and the value of these providers, whether it's alignment to a facility or a physician to physician. And the next example highlights that physician to physician. This is where we are leveraging EcoPath here to understand the volume of cardiologists and their alignment here to an ACO. So again, on the left-hand side, you'll see this is just the universe of cardiologists, and on the right-hand side, drilling deeper into the analysis is how cardiologists align with one particular ACO. Now looking at performance, again, from a cost and quality perspective within an ecosystem, we've been able to gather sets of data from Medicare, states, facilities, and claims sources. EcoPath now creates a modeling approach tailored to the system's needs that includes measures of market performance, missing data gaps, and areas of opportunity. Gaining insight into not only the provider relationships, but the efficiencies of these providers are a fundamental element in building relationships with providers, which we know can lead to improved member experience and delivery of care. Aggregating the network performance and developing a rating methodology for physicians is key. Glenridge has developed unique quantitative analytic tools that mines the public and private data sources to measure and rank physician utilization performance. This analytical platform enables the calculation of single metric of efficiency and overall ease of ranking of physicians. The efficiency profiling seeks to understand the relative efficiency of these healthcare providers. The next slide highlights, again, some more detailed reports at the individual specialty areas as well as globally for your ACO between the participating and non-participating efficiency components, as well as detailed by the actual specialties and the individual providers. So overall, another element is understanding the value of your ACO to a payer. So we have some additional tools that will help you align your value-based risk arrangement based on your value to the payer. So here's where we're able to help you identify your relative risks and the weaknesses of your organization and assess your capabilities to provide accountable care.
And so jumping into that and understanding from a payer's perspective what that looks like, we looked before at an ACO lens from an ACO's perspective. But from a payer's perspective, what they're looking at is an entire region. So if you happen to be in 4 counties in a region, if we just get very specific and think about Medicare Advantage for a minute, a payer is going to be looking at which counties they want to participate in or which counties they are participating in Medicare Advantage, and they're going to evaluate not only overall performance of the health plan, but they are going to look at county-specific performance because they can make choices as to which counties they want to participate in under Medicare Advantage. So, for example, if you're in Florida and you offer a Medicare Advantage plan in the Miami, Fort Lauderdale, Palm Beach area, a health plan could decide that they only want to participate in Miami-Dade County and no longer in Broward County. If you're in the Orlando region and and a payer could say, I want to offer this in Orange County, but I don't want to offer it in Seminole County. So although that doesn't necessarily make sense from a healthcare delivery system perspective, it could make sense from a financial perspective. And so a payer is going to look at the county attractiveness from the financial perspective of a payer. So how much is reimbursement to them from the government for Medicare Advantage? What amount of premium dollar are they going to get from the beneficiary, if any? And then how much do healthcare costs cost in a given county relative to that? What types of provider arrangements do they have to put in place? We see a lot of rural areas where the reimbursement from CMS may actually be quite attractive. And you would look at it at first glance and say, oh, this would be great. But then once you look at it, because there aren't that many providers in the region, the providers in the region may actually demand much higher premiums on Medicare for their reimbursement levels from the payer because they're the only person in town, and as a result, the health plan can't go into that given county. And so the health plan on the left side of the page is looking at what does the attractiveness look like in this given county, and then how many beneficiaries are there? Is it even worth the trip? Is it even worth me offering a health plan? Is there enough there? And then on the right side is where they start to factor in another layer of ACO. So we've seen an increasing number of payers now that before deciding to expand into a given region or even pull out of a given region, they look at the network adequacy that they have with various complements of provider systems. So we've had payers say, okay, I'm looking at going into, Bayer County, Texas. And we say, okay. And then they say, and I think I could get an agreement in place with ACO, XYZ. And here is the provider list of ACO XYZ, and here's the claims data for ACO XYZ. What does that give me in terms of adequacy if I want to file with CMS to get approval in this given county? And then we can overlay that with attractiveness of a given county, and they can start to look at it and say, hey, if I could contract with these 3 different ACOs, then I could go into this given county. And then my ACO partners need to deliver at a certain level, and if they don't, it's not worth me entering that given market. So it's starting to understand, again, understanding your performance, and then understanding your performance not only from an ACO's perspective, but as a payer, as an assumer of risk. So you may never own the insurance license, you may never have full insurance risk, you may only take a portion of it, but you're still managing the actual spend of the premium dollar as it relates to healthcare, and you're understanding where it's going. So the other piece of this is actually understanding how your network looks from a payer's lens. So, we talk about geo-access and adequacy, and that's fine, but it changes with every employer group, with every segment, with every market. So you may believe that geo-access standards are, one PCP within, 100 yards of your house. But the truth of the matter is Medicare Advantage has one set of regulations, Medicaid has another set of regulations, the exchanges have another set of regulations, and then every commercial payer has their own set, and et cetera, et cetera, et cetera. And so, again, it's saying, okay, I want to look at the following segments that I want my ACO to participate in. What value does my ACO bring from a network adequacy perspective from these different types of programs and these different types of segments? And then modeling out what that looks like. Then what you do is, instead of only focusing on a provider's performance in your ACO from a cost and quality perspective and how well they're aligned to their peers and their providers in there, you also start to look at how important are they to your ACO actually offering significant adequacy to a payer. Because if you just have a bunch of providers that don't really operate together in an ecosystem, they don't really work as a system, they don't really provide any level of adequacy for anything, your ability to assume risk and get a meaningful relationship with them is much lower. So it's being smart about understanding what you are providing and what you're delivering. Again, not just for the sake of the MSSP metrics, but for the end game, the larger piece of taking value as a system of care. So again, we talked about this for anybody that was on our call a couple of weeks ago. We did talk about decision support around evaluating where to take risk and or be a health plan. This shows you that a lot of our clients will say, you know what, we really should look at ourselves and how we perform and what it would mean if we were a health plan. Okay, so in our given region, there's X number of lives to be had. Well, how many lives do we actually control? How many lives do we actually influence? What amount of risk could we even take? What change could we actually effectuate and influence in a given region? And what does that even mean? And a lot of times that first step is important. And it leads them to the next piece, which is where do I want to take risk? What segment, knowing my performance, if you back all the way up to the sequence of slides we talked about, is how well are my physicians aligned by segment? How well are they performing by segment? What areas are they really strong? What areas are they really weak? Then you layer in, what does the health plan landscape look like in your region? And then you start to unpack and say, hey, you know what, it would really make a lot of sense for us to take risk on Medicare Advantage. It would really make sense for us to try to partner with the co-op exchange plan to try to do something to offer a different level of care. We'd like to do a small employer group option in our market because there's a lack there, and we think we could go to the regional commercial player and do something unique. There are a lot of new things out there and a lot of opportunities that folks aren't pursuing because they don't understand where their strengths are and what kind of value they offer to the payer. So once you've done this, once you've evaluated and figured it out, the other piece is you also need to have ongoing ACO monitoring. And this is another area of real analysis paralysis. So if you take all of the different quality measures that a given ACO or health system is measuring, it could go on for reams of paper. And sometimes the simple act of putting a dashboard together of all the metrics for which you're being incented through some type of value-based arrangement, just making a comprehensive dashboard is a place to start. And then start to look at how many dollars are really attributed to these different metrics. So if doing this HEDIS measure, right? How much incentive do I really get for performing on that HEDIS measure? And could I get more? Or should I be focused less or should I be focused more? And so you can start to then use these metrics and this performance to effectuate where you focus your energy and your effort as an ACO. A lot of times, the biggest rewards could be had from the lowest hanging fruit and the easiest blocking and tackling tasks. And there's a lot of untapped rewards that are sitting there for the taking that a lot of people aren't even aware of because they're too focused on the 33 or 34 or 36, whatever year it is, right, MSSP measures, when in fact that ACO is the vehicle for value-based reimbursement in a number of other segments and a number of other opportunities that are likely far more lucrative and would probably keep the ACO alive. We're hearing a lot of clients say, I'm thinking that we might even not continue to have our ACO anymore because we aren't doing well on MSSP. So, it's a real need. And then tracking and performing your metrics and then making sure that you have, like we talked about, incentive programs to retain your highly aligned providers. And it's rewards, it's not just incentives, and making sure that you can engage them. And reporting outcomes, I'm sure everyone on this call is well aware that just sending out an unblinded peer report of performance in your ACO can do wonders for engaging physicians and changing behaviors. So reporting that, but then also, as we talked about, reporting it as a whole ecosystem. It's really important for your providers to not only understand that cardiologist A did X, Y, Z, but to understand how your behavior affected this primary care physician and impacted this hospital and impacted this other, subspecialist, but understanding how they are a piece and part of a much larger ecosystem of care delivery than just their little world and their little piece. And then having this type of sophistication, this type of monitoring and tracking and data and aligned incentives is a very powerful tool for recruiting new providers. Providers want to join accountable care organizations where they can really be rewarded and they can succeed over the long run. And this is the type of data and incentive and knowledge that they're seeking in the tools and the programs they want to be a part of. A lot of times, too, it's the blocking and tackling of just tracking and monitoring your network. We have a tool that we use that helps our clients project manage and develop their network. So it's almost, if you think about it, sort of a CRM tool, but for network development. So by doing this, you can cleanse your data, you can look at the adequacy, you can identify and quantify the impact of certain providers in your ACO, and then you can, on an ongoing basis, use a web-based tool to recruit and then track and monitor your recruiting efforts, so that anybody can take a look and say, okay, this is our ACO, we're trying to recruit this practice of cardiologists over here, we're trying to get this multi-specialty group over there, we're trying to get this payer, and having one central web-based repository where people can go and track all of the activity that's happening for that and understand why and how, and then prioritizing that can go a long way for an organization. So in closing, so that we can allow a few minutes for questions, is, optimizing your case mix and strengthening your referral networks. We talked about managing referral leakage, expanding key service line and geographic opportunities. All of this leads to that, which is where folks really want to go anyways. Pinpointing the right providers to engage. So notice we don't talk about kicking providers out of the network or, only getting new providers. It's engaging providers. So data and education and information and incentives and rewards are all part of the engagement process. And a lot of times behaviors change just by those simple acts as opposed to having to terminate somebody from your ACO. And it also helps you understand those providers that you really do want to keep happy, that are really important on a number of different levels. Conduct readiness assessments in terms of all of these different products and segments and payers and arrangements. Risk is a lot less risky when you understand the sensitivity and likelihood of either succeeding or not succeeding. It's not just modeling out a P&L. It's looking at what happens if the wheels fall off the bus of this relationship. And by the time you put stop loss on it, and by the time you look at a 50-50 risk share, and you look at the actual attributed lives that you would have in the arrangements, a lot of times the amount of risk that you're assuming is far less than people believe. And the behaviors that those arrangements impact as a result are far more valuable than the small amount of risk that you're taking. And again, a lot of people just, because of what they don't know, they're much more fearful. And then finally, engaging your providers in risk-sharing discussions and leveraging your data and technology to enable providers to accept risk. So with that, I will ask folks to please submit questions online, and we will pause and see if we get any questions. So one of the questions asked was, do we also evaluate post-acute providers? And the answer is yes, absolutely, and it just depends on what referral patterns and activities that we're trying to look at, but we can evaluate and do like to evaluate post-acute providers because they're a very important part of the provider ecosystem. Another question that came in is, what type of data or info would you need from my ACO to run an ecopath analysis? So so it depends on the level of analysis that you would want to do. So if you just want to understand alignment and basic efficiency, then all we need is a list of NPIs and providers to be able to look at that level of data. But if you are able to actually supply claims data, then we can go into another level of evaluation in terms of cost and value, and we can actually simulate some HEDIS measure performance and star rating impacts. So we could say, okay, if you were to do a risk arrangement with a Medicare Advantage plan and you were to do a percent of premium, then what amount of premium would your star rate, what star rating in essence are your providers delivering to the health plan that you want to do this contract with, and how likely are you to succeed in that arrangement? Another question that came in is, how do we incorporate behavioral health? And I do have the ability to see who asked the question. And I will say that on that one, I'd like to get some more information to answer it because it just depends on what we're trying to get to and what data set that we're using. But we do try to look at the whole picture of care delivery. So we have incorporated it before, but again, I'd have to do a level of sleuthing and sort of back and forth that I don't think I'm going to be able to do online. So I will follow up with you via email to try to address it. Okay, well, I think that's it. We will, I don't see any more questions coming in, so I will give everybody 8 minutes back in their day, and we appreciate your time and look forward to talking with any of you or having you on our future webinars. Thanks for your participation.